Thank you so much. Good morning, everyone. The Human Service Joint Subcommittee meeting will now come to order. Will the Committee Secretary please call the roll?
Senator Cannizzaro.
Here.
Senator Dondero Loop.
Here.
Senator Hammond.
Here.
Senator Kiekefer.
Here.
Senator Ratty.
Here.
Assemblywoman Benitez Thompson.
Good morning.
Assemblywoman Carlton.
Here.
Assemblyman Frierson. Assemblyman Roberts.
Here. Sorry.
Assemblywoman Titus.
Here.
Assemblywoman Tolles.
Here.
Assemblyman Watts.
Here.
And Chairman Ro Moreno.
Thank you, and I am here. Would you please mark Assemblyman Speaker Frierson absent excused? I'd like to welcome everyone to today's meeting. Today we will be hearing 6 budgets from the Department of Public and Behavioral Health. But before we get started, just a short overview. The building remains closed and everything will be conducted virtually. For the members on the committee, if you would keep your cameras on and all your electronic devices silenced, it helps with the background noise. And for the community that's watching, you will be able to give public comment at the end of today's meeting. So without further delay, I will invite Administrator Sherrick to the virtual committee room, and you can start with your presentations. We will stop you at the end of your presentation on each budget because we do have a few questions as we go through. So welcome to the meeting, and the floor is yours as soon as you're ready to get started.
Good morning. My name is Lisa Sherrick, Administrator for the Division of Public and Behavioral Health. Here with me today is Joe Millay, Deputy Administrator for Clinical Services to my left, Debbie Reynolds, Deputy Administrator for Administrative Services directly behind me. And also here with me today is Dr. Stephanie Woodard, our DHHS Senior Behavioral Health Advisor, behind me to the left. And as well, we have Dr. Elizabeth Neighbors, who's joining us via Zoom, who is our statewide forensic director. Slide 2 through 4 provides an overview of our division's vision, mission, org chart, and services provided under DBPH. Slide 5 and 6 provides a snapshot of the division's requested funding for FY 22-23 and biennium account summary for the behavioral health budgets we will be covering today, highlighted in green. Slide 7 provides an overview of COVID-19 funding received in our behavioral health budget accounts, totaling over $38.6 million. And slide 8 provides an overview of this funding broken down by the Federal Authorization Act. Specific to slide 7, we have received over $32.7 million in federal grant funds awarded to support the expansion of mental health treatment in emergency rooms and crisis counseling assistance of first responders, healthcare workers, and families whose family member was affected by COVID-19. I do credit the Bureau of Behavioral Health, Prevention and Wellness, along with our fiscal, HR, and contract unit staff for ensuring we were able to stand up these crucial programs within very tight deadlines. We also received just over $533,000 in CARES Act provider relief funds because SNAMs and NAMs are CMS certified psychiatric hospitals. The funds received by SNAMs has been reverted to general fund at FY20 closing, and NAM's FY21 reversion is pending. Lastly, we have received over $5 million in CARES Relief Treasury funds, also known as CRF, authorized through the Governor's Finance Office to support mobile outreach safety teams in the North and South, rural mobile crisis response, mental health youth suicide prevention, as well as reimbursement for salaries and operating costs, including implementation of infection control measures for prevention and spread of COVID-19 for our hospitals and clinics, including additional PPE, as well as equipment provided for those who are able to telecommute. Before we go through the behavioral health budgets, I just want to start by explaining that our agency requested budget included general fund reductions of $31 million over the biennium. We are sincerely grateful that many of these reductions were added back by the governor. However, there are still some reductions that remain and will have an impact. We tried to limit the impact of the reductions to the direct services provided by DBPH and to our staff who provide these services. The majority of our general fund is in our clinical services budgets, which provide direct services through NAMS, SNAMS, and rural clinics. The budgets before you today include an overall reduction of just over $4 million in FY22 and just over $855,000 in FY23. It's also important to note that we transfer a significant amount of Category 1 vacancy savings each year to cover contract positions in Category 8 professional services and Category 9, which is our mental health technician services. So it's important to maintain an adequate level of vacancy savings, particularly at SNAMS and NAMS and Lakes Crossing, as these categories are reliant on vacancy savings to fund direct services provided by contract positions. Slide 9 provides an overview of Behavioral Health Administration, Budget Account 3168. This budget account supports the behavioral health budget accounts we will be reviewing today, and also provides support to the Commission on Behavioral Health and funds the Central Billing Unit and the Nevada Psychology Intern Consortium, otherwise known as NVPIC. NVPIC was created to offer quality training to clinical psychology doctoral students with hopes of retaining them to become licensed psychologists in the state. NVPIC represents the collaborative effort of DBPH training sites at Southern Nevada Adult Mental Health Services and rural clinics to share resources in psychology training faculty for the purpose of providing a diversified educational program for doctoral psychology interns. Since its inception in August 2015, NVPIC has had 17 students. Of those, 9 stayed in Nevada and 7 were hired by the state. Currently, 4 are employed by the state. Moving to slide 10, we are requesting a cost allocation redistribution to remove general fund in the administrative accounts and fund the full cost allocation into the behavioral health accounts. This affects our public health administrative account 3223, which was discussed during our public health budget presentation on February 23rd, as well as our behavioral health administrative account 3168. The 2019 legislature issued a letter of intent directing DBPH to appropriately allocate administrative costs to the behavioral health budgets so that they are treated consistently with the other divisions' budgets that receive central administrative support. Specifically, the Joint Money Committees directed us to review our cost allocation charges and consider including the division-wide administrative costs proportional to the services provided to the behavioral health budgets. By removing the general fund in the administrative accounts and instead budgeting the general fund in the behavioral health accounts and transferring through the cost allocation, it allows the division-wide administrative costs to be proportionally budgeted based on the actual administrative oversight and support provided to the behavioral health budgets, as requested by the legislature in the letter of intent. This concludes the major enhancements in this budget account. Does the committee have any questions?
Good morning, and thank you for that presentation. I know we do have maybe just a few questions, and we'll start with Assemblywoman Carlton.
And thank you very much, Madam Chair. So I guess if you could just expand a little bit upon the statewide allocation, the SWICAP, whatever acronym we want to use for that, what the thought process behind that is. I think you're trying to get more transparency, if I understand the proposal correctly, and it will address the services that you provide across all the different budget accounts. So could you just expand on that a little bit, please? And then I have a question about the psychology interns.
Thank you for the question, Debbie Reynolds for the record. To elaborate on the request to redistribute the cost allocation, the intent is to ensure that the administrative support that's provided to the behavioral health accounts is appropriately budgeted in their accounts and then transferred to the administrative accounts. To give you a little bit of an example, in FY20, there was $528,000 budgeted in both administrative accounts, 3168 and 3223. Actual collected amount was 286,000. So this is the amount that was budgeted based on a percentage of Medicaid revenue to the overall revenue in the budget, but it wasn't based on the actual administrative support provided to those budgets. The administrative support provided to those budgets includes administration staff, it includes HR, and also IT staff. And so allowing us to redistribute the cost allocation actually allows us to appropriately allocate the behavioral health administrative support provided to those budgets. I hope that answers your question.
Yes, it does. It makes it a bit clearer for those that don't understand how we do the cost allocation program. So, and it does allow us to track, and it gives you hard numbers moving forward in order to be able to make the correct ask for funding in future bienniums. So I appreciate you moving towards that, and this will be totally cost neutral. So it's not like there's going to be a cut involved. It's just a matter of how the dollars are apportioned out. On the psychology internships, can you let us know? I mean, we've always wanted to grow our own, and the idea was to get them here, sort of like the GME program, get them here, get them going. Hopefully we'll be able to keep them. How many folks are we looking at, and how successful have we been?
Is that Dr. Butter?
Hi, Lisa Sherrick for the record. So I think with having 17 students being able to go through the program and doing quick math, 16 of them actually staying in Nevada, I do believe it is a successful program. You know, we continue to work through this program, and I believe there's a new one already identified for this year, but I'd have to get that specifics for you. But I think 16 out of 17 in the program staying in Nevada does demonstrate success.
Thank you very much. It's nice to know that something we all came up with is working, and hopefully we can keep more of them here and address the access issues that we have. Thank you very much.
Members, any other questions on this budget? Okay, seeing none, we will move on to budget 3200.
Lisa Sherrick for the record. Slide 11 provides an overview of problem gambling, budget account 3200. In 2005, the Nevada State Legislature passed Senate Bill 357 to create the revolving account for the prevention and treatment of problem gambling, and an advisory committee on problem gambling to advise the Department of Health and Human Services in its administration of this account. The 2019 legislature did not approve the governor's recommendation to change the primary funding source for this budget from quarterly slot tax revenue to gaming percentage fee revenue imposed by NRS 463.370. Instead, the subcommittee recommended changing the primary source for this budget account to general fund appropriations. The committee assists in the establishment of priorities and criteria for funding programs and services for the prevention and treatment of problem gambling, reviews recommendations by the department for granting money or contracting for services for the prevention and treatment of problem gambling, and makes recommendations to the director concerning the award of such grants and contracts. Slide 12. This budget is 100% funded with state general fund. E686. Due to required budget reductions, this decision unit reduces problem gambling services by $176,000 each year of the biennium. The Advisory Council on Problem Gambling will determine how to allocate the budget once finalized. E902 transfers one social services specialist FTE from budget account 3170 to better align duties of the position. This position is 100% dedicated to the problem gambling program. Under the current structure, budget account 3170 pays for the position and all associated operating costs, then is reimbursed from budget account 3200. The transfer of this position will allow budget account 3200 to pay for the position and associated operating costs directly, eliminating the need for a transfer between the two budget accounts. This concludes the major enhancements in this budget. Does the committee have any questions?
Thank you. Yes, we do. We'll start with Assemblyman Watts.
Thank you so much, Madam Chair, and thank you for the presentation. I know this is also something that we were discussing quite a bit during the special session. I was just wondering if you could give us a little bit more background on the program itself, especially over the last biennium. How many people did the agency support in getting treatment, and how did the pandemic impact the activities under this program?
Hi, Lisa Sherrick for the record. In FY20, there were 436 treatment clients. And so far in FY21, there's been 177 treatment clients. It appears that the average cost per client is about $2,775. And there is about only 11% of the clients are approved for Medicaid. As far as COVID, the COVID impact, during FY20, all funds were allocated to be spent on track for, were allocated to be spent and on track for complete spending. But due to COVID-19 and the state mandated restriction, the subrecipients were not able to spend all the funds. This is due to the governor's required lockdowns, social distancing restrictions, and then budget restrictions gambling treatment providers had in regards to the decrease in services. So I don't know if you want further details about the program, but happy to answer that if that was not sufficient.
Thank you. No, I think that was sufficient. That leads me to a second question. So with the impact that the pandemic had on treatment services, was there any shift to prevention and research activities over the last year or so?
Good morning, Stephanie Woodard for the record. There's consistent oversight over the spending that's happening with all of the providers and other contracted programs such as prevention and research. And so the committee is actually actively reviewing if there needs to be a reallocation to prevention and research services for the remainder of this year.
Okay, so just to clarify, that's something that's being looked at but hasn't happened yet.
Correct. There's been quite a bit of conversation. What we're seeing is that because of COVID, we had fewer admissions into treatment. However, the admissions for treatment are beginning to pick up. And so we want to make sure that we allocate appropriately and don't undercut the necessary funding in order to be able to support the increased demand for the remainder of the year.
Thank you. I appreciate that. I understand with things starting to open back up, we are likely to see an increase in the need for treatment. I just have one last question, and I was just wondering if you described in dollar amounts the proposed budget reductions. Can you describe and I know that you said that the allocations to the recipients will still have to be made afterward, but can you give any estimate of the effects that these program reductions would have on our problem gambling services here in the state over the next biennium?
Lisa Sherrick for the record. If the total $176,000 each year or reduced each year went directly as a reduction to treatment services, I would anticipate that this would equate to about 63 additional individuals each year not being able to access those direct services.
Thank you. That's all the questions that I have, Madam Chair. Thank you.
Thank you, Assemblyman Watts. Members, does anyone else have a question for budget 3200? Okay, seeing none, we will move on to the next budget on our agenda, which is 3170.
Slide 13, Lisa Sherrick for the record. Slide 13 provides an overview of behavioral health, wellness, prevention, and treatment budget account 3170. This budget account is accountable for developing community infrastructure, such as applying for eligible grants, grants management, statewide leadership, and strategic planning. This budget account also includes integrated mental health, substance abuse, and co-occurring disorders, including the development and submission of the biannual joint mental health substance abuse block grant. Slide 14. This budget is primarily funded with federal funds, as well as general fund, which is used to match the federal block grants and other revenue, which includes transfer revenue and certification fees. E225 requests to convert 4 positions into FTEs, including 3 health program specialist 1s and 1 administrative assistant 3. E900, this request transfers 1 psychologist position from rural clinics, budget account 3648, to better align duties of the position. This position is the statewide disaster behavioral health coordinator, responsible to support all departments and county officials in the communities across Nevada to develop behavioral health disaster response plans as part of AB 206. This position is important as the state enters the recovery phase of COVID-19. Slide 15. E901 transfers the Office of Suicide Prevention, or OSP, from Maternal and Child Health budget account 3222 to 3170. This transfer aligns with the Bureau's oversight of the state's behavioral health programs and improves alignment with the mission and vision of the programs. OSP is responsible to develop, implement, and evaluate the state suicide prevention strategy, provide wellness, early identification, intervention, and prevention of suicide services, provides the signs of suicide education and screening program, and supports crisis prevention awareness, education, and training, to name a few. E910 transfers 1 health program specialist 1, 1 health program specialist 2, and 1 biostatistician 2 FTE to the director's office as part of the department-wide standardization for the Office of Analytics, as previously mentioned during the public health budget presentation on February 23rd. Slide 16. E490 eliminates revenue and expenditures for the emergency COVID-19 grant from the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. This decision unit was added because the original grant award was ending on August 19th, 2021. However, a supplemental award was received on January 15th, 2021, and the new budget and projected project period ends on 5/31/2022. On January 15th, 2021, the division received supplemental funds to this award from February 1st, 2021 to May 31st, 2022 in the amount of just over $2,767,000. Now that this award has been extended, we would like to work with your fiscal staff to keep authority through the end of the new budget period. And with that, that concludes our presentation for this budget. And does the committee have any questions?
Thank you. Yes, we do have a few members with questions. We will start with Assemblywoman Benitez Thompson.
Thank you so much. So before I get into kind of more specifics of 3170, I had a question more about the 32.7 million of federal dollars that came through. So I don't see any of that money landing in some of the specific programs that we have. Was all of that granted out to outside agencies?
I can start. And also for the record, Just to clarify, 24 million of the 32 million that's listed was just received in grant awards last week. And we will be submitting work programs to request authority to spend those dollars. So those additional funds have not actually been allocated out to the community yet. As far as the existing $8 million, those funds have been obligated, and I will turn it over to Dr. Woodard to elaborate on that.
So aside from the, Stephanie Woodard for the record, aside from the additional dollars that we just received last week, all of those dollars have been obligated and have been subawarded out to the communities. We continue to evaluate what the needs are because the situations related to behavioral health treatment and needs in our communities continues to unfold. So we look forward to pushing out competitive RFAs to ensure that we are addressing all of those needs with the new federal funds that we just received.
Thank you so much. Can I ask a follow-up question, Madam Chair?
Yes, please.
Okay, so with the competitive RFAs, I guess because I look at some of the budgets we have here and I look at some of the decisions we're going to have to make in position eliminations and different things like that, but you see some pots of money that typically you would think are starving for dollars. So the suicide prevention lifeline, all of our suicide prevention programs where there's a proposal to move the office around in one of these, I think in this budget specifically, in this budget specifically, we've got, early diversion programs and different things in here. So I guess of that 8 million, what pieces of those 8 million landed in Nevada state kind of supported programs versus going out for competitive bid?
So Stephanie Woodard for the record, all of those funds actually went out to the community to specifically address the needs related to behavioral health and COVID. What we have done is funded hospitals to help to relieve some of the backlog that we were seeing in emergency rooms, especially with COVID and the medical surge. We knew that we needed to move very quickly to help to move individuals who needed higher levels of care out of emergency rooms and into inpatient treatment. So we have funded 2 hospitals specifically to be able to do psychiatric triage to address individuals who are in crisis, and then pay for individuals who were either underinsured or uninsured to ensure that they could access the appropriate level of care. We were also required to do some set-aside funding. So 10% of the COVID funds, COVID ER funds, were required to go towards healthcare providers. And that was allocated to UNLV to establish a warm line for healthcare providers, as well as some CME classes for supporting wellness. And then DCFS actually has received some funds to support the expansion of children's mobile crisis, specifically to expand access 24/7 statewide.
Thank you. And I want to say that as we've been talking about all this money and trying to keep track of what's been going where, remember the UNLV, the warm line. I don't think I recall the psychiatric triage to hospitals. I'm sure you have it somewhere. I don't want to ask anyone to do more work, but if we could just get that rundown, or if you want to point me to where it already is, if we already asked in a previous IFC meeting or when we were approving these funds, I can go back to those work documents on that. I just wanted kind of to make sure that I understood where all of that went. And then it sounds like we'll be hearing from you about where the additional 24 million that we got notice of will go to. I would just make the plea that some of the state programs and offices that we've stood up, once again, I think that the competitive grant programs are good, but I also want to balance it with seeing some of our own FTEs who do this great work also being empowered to continue the good work that they do.
And Stephanie Woodard, for the record, yes, we will follow up with additional information. I also want to reiterate that some of these funds went to standing up our crisis counseling assistance and training program. That was done through a number of contract positions that the state ended up hiring to be able to provide specifically to communities. It was the fastest way that we were able to stand up that program. And so instead of doing a competitive bid for that program, we did actually directly fund those positions and then allocate it across communities. And we have been working very closely with the Office of Suicide Prevention. So when and where some of those funds have been available to support suicide prevention activities and trainings, as well as further support for the crisis line, as you had mentioned, we are doing so. So we're consistently evaluating where we can support state programs in addition to community programs so that we can continue to make sure that those programs at the state level also are viable.
Could you the four, I think, did you say the four contract positions that are going to 3 full-time health program specialists? Are those positions that you mentioned?
No, those are positions that have been supporting other grants, including our block grants. And as you know, block grant allocations come in annually. We have had some difficulty filling those contract positions and maintaining the expertise that we develop in those positions as they leave for other positions. So we're hoping that being able to convert those positions to FTE will help us actually recruit and retain qualified individuals and really help them move forward in the progress of developing that expertise and maintaining them in our positions.
Did you have a follow-up, Assemblywoman?
No, I don't think so. I just wanted to make sure that I was thinking of the right positions. We talk about so many positions and so many budgets, so I think I might have been thinking of a different set of positions. But I've asked staff to help clarify to make sure I'm thinking of all of the different funding sources for the different positions we're talking about. Thank you.
Thank you. Assemblywoman Titus?
Thank you, Madam Chair. I have a question regarding the transferring of the psychologist from the rural clinics and moving that position over. We've heard that you have difficulty finding positions. You've testified on the concerns about mental health, especially with this COVID pandemic, and on the difficulty of finding providers in rural areas. And I'm just concerned that we're moving that position out as opposed to just creating a new position and keeping the rural psychologist in that same position. Can you give me what the thoughts were behind that particular decision unit?
Lisa Sherrick for the record. So that position has been working with rural clinics, but more in regards to the statewide disaster behavioral health plan that is really needed. We have been assessing the caseloads and the services through rural clinics, and we do believe that this is a position that can be afforded to transfer over to 3170. Additionally, and I lost my train of thought, sorry. Oh, go ahead, sorry.
Jill Millay for the record. Just to clarify that psychologist has been hard to fill in the rules. Currently, it's with a position that is in an urban area and helping with that with the program. However, it does have a slight impact on our services in rural health, and that the psychological testing of individuals in rural clinics will be delayed a little bit longer. Currently, we already have about a 2-month waiting list for those psych testing, so we expect that to increase about 3 to 4 months.
And Lisa Sherrick for the record, my thought came back to me. Just based on the economic situation that we've been facing this past year, it didn't seem to be in the best interest to request an additional position that would be general funded.
Okay, I do have some concerns, and I'll ask on the next budget we have, I have even greater concerns, and then to see this one also, when we know it's hard to fill. And what I think I heard you say is the position now is currently being filled by somebody in an urban area that's been doing some assistance. You already have a 2 months waiting list. This is going to solve a problem. I just don't see that will help. But again, I'm just putting my concerns on the record. The next question I have is, you mentioned, our Majority Floor Leader mentioned the several millions of dollars you've gotten that we don't see in this budget. We're worried about some of the process happening here. We mentioned suicide prevention. I'm wondering if there's any push to do the 988 calls. I don't see anything in any of this budget. I know it's a national priority. There's been some discussion this year. Are we working on that?
So Lisa Sherrick, for the record, I just wanted to clarify based on your first question about the psychologist being placed in an urban area. That position currently is vacant. The person vacated a couple months ago. They retired. So I do think we have some opportunity to, relook at that and where that position would be located, since it does support statewide efforts. Regarding the 988, I will turn that over to Dr. Woodard.
Stephanie Woodard for the record. So Crisis Support Services of Nevada is our national suicide prevention hotline here in the state. It is those hotlines that have been prioritized to stand up the 988 systems. We have, through our crisis counseling and assistance and training program, provided them 5 additional staff. We also have a Lifeline expansion grant that has supported them in expanding their services to be able to answer more in-state calls. And actually, we have not only met, but exceeded what the expectations were in a relatively short period of time for us to be able to answer a sufficient number of in-state calls. With some of the additional COVID ER SAMHSA funds, we are also going to be funding an additional 6 positions so that we can really begin to staff up the 988 line. With the new infusion of federal funds, so the mental health and substance abuse block grant dollars that we just received last week, there is a priority on those funds to make sure that we are using them to build out our crisis system of care, which includes 988. So we will be working with SAMHSA to actively determine what level of funding we can devote to not only 988, but also mobile crisis and crisis stabilization centers. Those have been major priorities for us. So when we have been able to get funding in, we have been able to identify which funding is most appropriate to be able to continue to build the infrastructure necessary to stand up 988 and the entire crisis continuum.
Great, thank you for that. Thank you, Madam Chair, for the question. And just a comment that when you get that plan put together, when you have those monies on what the pathway will be to make that 988 viable and advertising that and make sure folks understand how they can access that, I think we would all like to have some follow-up on that. And thank you, Madam Chair, for the questions.
Thank you so much. And we have just a few more questions before we end this budget. And I'll go to Senator Dondero Loop.
Thank you so much, Madam Chair, and thank you to the staff for presenting this. And I have a couple questions, and hopefully they haven't been intertwined in other answers already, but I want to be clear. So can you explain why the Substance Abuse Treatment and Treatment Agency is recommending that we're transferring those contract positions over to permanent state positions?
Stephanie Woodard for the record. Again, yes, these are positions that support longstanding grant activities. And we have had a difficult time maintaining contractors in these positions for the longevity of the grants that they oversee. So what we have found is that we've had a difficult time filling the contract positions. And then when we do fill them, there is an enormous amount of learning that needs to happen in order for them to develop the depth of knowledge needed in order for them to perform these functions. And so we've had a difficult time also then retaining contract positions when we know that they would opt for an FTE with benefits and all of the other real benefits that come with state employment. So we see that converting these positions to FTE will allow us to recruit and retain highly qualified individuals for these positions, and hopefully allow them to stay within the programs long enough that they can really develop the expertise and provide what is needed to the program.
Thank you very much, because you answered the second part of that question that I was going to ask about, giving me the advantages of that. So then with that, would you please provide an update of the work of the suicide prevention office and including its activities during the coronavirus? Because I know that that's been an issue, and I've been working on some of that and have some bills that I've brought forward. So if you could give us an update on that, it would be very much appreciated.
Sure. So Stephanie Woodard for the record. We've been working very closely with the Office of Suicide Prevention on a number of different initiatives. So early on in the pandemic, we established a behavioral health task force, which actively involved the Office of Suicide Prevention and developed a behavioral health recovery plan for COVID. We've been using that plan to really guide much of our activities. They have provided suicide prevention training and consultation to our resilience ambassadors that are funded out of the Crisis Counseling Assistance and Training Program. They have trained over 3,500 individuals this year on suicide prevention. And this includes assist, safe talk, gatekeeper training. They also do youth mental health first aid training. One of the issues that we continue to run into, and we are always looking for additional federal funds, is that many of the funds that we standardly get from SAMHSA are not allowed for prevention activities related to suicide prevention. And so we continuously are looking to establish additional funding streams with federal dollars to be able to meet the needs. The good news is that, as I mentioned, the additional block grant funds that we just received last week are allowing us to do a bit more of an expansion of what is allowed under those dollars. So we will be working with SAMHSA to determine what additional activities we can fund with those dollars that previously would have been prohibited. In addition, sorry, were you going to say something? Okay. In addition, our state opioid response grant funding, we have been supporting the Office of Suicide Prevention in the Zero Suicide Initiative. We are happy to say that we've got 16 hospitals that have signed on to the Zero Suicide Initiative, and the staff that is leading the charge has actively recruited additional hospitals and healthcare systems to also implement zero suicide. And we are funding a biostatistician who will then be able to assist us in gathering all of suicide-related data so that we can continue to formulate what our plan is to address suicide prevention and postvention in Nevada.
Thank you. No, I got ahead of myself as I was listening. So who are those 3,500 individuals that you have trained? Do they ever reach down into the schools?
Stephanie Woodard for the record, yes. Office of Suicide Prevention has a long-standing collaborative relationship with the Department of Education and school districts. We have been providing support to Clark County School District and Washoe County. They provide additional ongoing consultation and training for a number of other groups, including first responders, parents, teachers, faith-based organizations. They have a very broad reach across the state with different role groups who identify a desire for suicide prevention training.
Well, that's perfect information. Thank you very much. And if you don't mind, I'd like to reach out to you offline to discuss something that I'm working on. So thank you very much. And thank you for what you do.
Thank you, Senator, for the questions. And in that dialogue, I have a question. As we've been living through this pandemic, could you tell us how are the service providers, the substance abuse prevention and the treatment agencies adjusting the challenges that have occurred during this pandemic?
Stephanie Woodard for the record, I would say that the vast majority of providers were able to pivot to using telehealth almost exclusively very early on in the pandemic. We offered additional funding and flexible funding if they were already receiving funding to help them to meet the needs for telehealth and their patients. We have seen a lot of demand for treatment services via telehealth. So most of them have been able to continue not only their lines of existing service, but including telehealth for increased access to care. We also know that behavioral health providers really struggled with maintaining staffing at adequate levels at various times during the pandemic, and especially for our residential treatment providers. Some of them had to really do additional work to make sure that the patients that were entering their facilities were COVID-free. And we did have outbreaks in some of our residential treatment facilities that were handled very quickly so that it could be contained. So we have seen some variable impact. At times, they haven't been able to admit as many people as they would have previously, but working within the entire network, most individuals who demonstrated a need for care, especially those higher levels of care, we were able to admit timely.
Thank you for that. I have some other questions about the mobile crisis, but I'll reach out to you offline with those. Members, any other questions on this budget before we move on to 3648? Okay, seeing none, we can move on.
Lisa Sherrick for the record. Before we move into our clinical services budgets for rural STAMs and NAMs, I'd like to acknowledge the hard work our clinical services team has done during the past year navigating COVID, while ensuring our hospitals and outpatient services throughout Nevada have continued to provide the necessary services to the community while ensuring protocols to reduce COVID impact were implemented. The ability for everyone to quickly pivot and move to telehealth services, develop quarantine units in our hospitals, and managing the overall stressors of this pandemic is truly appreciated, and I continue to be honored in having such an exceptional team at DBPH. You will note projected demand for DBPH clinical services at the end of FY23 begins to increase after an initial decrease during the early months of the pandemic. However, the overall average projection demonstrates a decline. Staffing coverage remains challenging due to the pandemic, and there are multiple position vacancies, but recruitment efforts continue. It should be noted that our caseload projections will be updated again by the Office of Analytics at the end of March, and we will provide updated projections to your fiscal staff. Clinical services provide services statewide in our inpatient hospitals and outpatient clinics to those with serious mental illness. Since the beginning of the pandemic, our caseloads have decreased or remained stable. While studies from entities such as Centers for Disease Control and Prevention and some Substance Abuse and Mental Health Services Administration show increased levels of anxiety and depression during and following a crisis, even such as the pandemic, our services have not reflected those increases. Data analysis of caseloads and medication utilization of 35,000 claims show no increase in those seeking mental health services provided by our hospitals and outpatient clinics. Call lines and early intervention services, such as mobile outreach teams, children's mobile crisis team, care teams, and rural extended access to community health, otherwise known as REACH, are first-line resources that provide rapid intervention that reduces anxiety. We've noted sometimes it could just be another person that understands and an offer of help. The intervention of these services assists individuals so that long-term services may not be needed. The ability to adapt to crisis with assistance from our state's early intervention services shows the resiliency of Nevadans. Slides 17 and 18 provide an overview of projected caseloads for clinical services. These slides, once again, we will be updating our caseload projections at the end of the month, which may result in the need to adjust our caseload decision units. The Office of Analytics determines projections from actual caseload numbers. As you can see, for NAMS, medication clinic caseload has been decreasing since September 2019. However, caseload projections at the end of FY23 are showing a slight increase. Outpatient services has stayed relatively stable throughout 2020. All other caseload has relatively been stable or decreased. For SNAMs, medication clinic caseload has stayed relatively stable. Outpatient services has been decreasing since February 2020. All other caseload has relatively been stable or decreased. For rural, medication clinic caseload has decreased since the start of the pandemic. However, caseload projections are showing slight increase to pre-pandemic levels. Counseling services has been decreasing since February 2020, and outpatient service coordination has been decreasing since May 2020. All other caseloads have been relatively been stable or decreased. Slide 19 provides an overview of rural clinics budget account 3648. Specifically, rural clinics provides outpatient behavioral health services to children and adults with mental illness in rural counties outside of Washoe and Clark. Slide 20. This budget is primarily funded with state general fund and small portion of federal grant funds and other revenues, including Medicaid, Medicare, and private insurance, as well as a transfer of Healthy Nevada funds from the Director's Office to support adult and children's rural mobile crisis services. Additionally, CRF Treasury funds were approved in FY21 to reimburse rural mobile crisis services. E6881 maintains 11.26 FTEs vacant through fiscal year 2022 with reinstatement in fiscal year 2023. Of note, rural services was experiencing a downward trend for services such as counseling from January 2020 until August 2020. Based on trend data, it was relevant to hold those positions vacant. In addition, based on the geographical locations, some services can be absorbed by neighboring town clinics to maintain access. As telehealth services increased during the pandemic due to CMS guidelines, it has allowed for increased flexibility of staffing and coverage. E682 aligns revenue from general fund to other sources for the purchase of replacement equipment. DBPH has confirmed with the Division of Healthcare Financing and Policy that these expenses are eligible when providing support for positions and operating costs. Slide 21. E686 reduces psychiatric services. This is our CAT 8 or Contract Professional Mental Health Services category, which has had an average savings of over $486,000 over the last 3 fiscal years. Service levels are not anticipated to be reduced and will be retained. Since this is across all rural services, there is not a clinic-specific impact. This concludes the major enhancements in this budget account. Does the committee have any questions?
Thank you so much. We do have a few questions, and we'll start with Senator Ratty.
Thank you, Chair. I'm, of course, always concerned about the vacancies. So how would those vacancies impact services in rural Nevada?
For the record, Joe Millay, sustaining the rural clinics, it was important to us as it is to the communities we serve, the clients we serve, and even the employees that work and live in those communities as well. Telehealth services really allowed us to have that flexibility and coverage and staffing where vacancies were. The vacancies were spread out amongst all the rural clinics, and so no one clinic was specifically can't be covered with those telehealth services. So we have looked at the flexibility of staffing for those vacancies. And as I mentioned earlier, one of them was a psychologist, of course, but we have our mental health counselors in our clinics also, that we have our clinic managers that can cover as needed as well. And though with telehealth services, though we don't have the entire treatment team right there on site, we always have someone in every clinic that greets them, can assist them, and assess them as needed.
Thank you for the answer. I think that probably one of the happy outcomes of the pandemic, if you will, has been the acceleration of the adoption of telehealth. And I think we're all very excited about that. I think, though, we also recognize that telehealth is not indicated for every interaction. And so I'm just wanting to dig in a little bit more about, particularly in rural Nevada, because I do think that everybody wants to just believe that telehealth is going to be the solution for all of the needs, but we know that there are folks who need a different modality than telehealth sometimes. So how are we managing to that as we're moving through the pandemic?
Thank you for the question, Joe Millay, for the record. Yes, and as we mentioned earlier, we do also have some early intervention services. One is our REACH team. That's the Rural Extended Access to Community Health team. That is a team of providers that no matter where a client would like to access services, we get a response to them and interventions to them quickly. The other point that we do is we have been working with the rural hospital partners in providing those interventions in the emergency rooms so that they get quick access. We consult with the ER physicians and nurses as well. We also have our mobile crisis teams as well for both adults and youth. So when a call comes in from either a parent or a youth, we have our team that goes out to those clients in order to provide intervention services. We have the rural clinics have been using telehealth for a long time. The rural health hospital partnerships and other partners throughout the counties have really expanded and worked with us to improve telehealth services. And so we continue to do that, also have clinic sites so that we can provide those services.
Thank you. That's helpful. And then I guess the other piece that I'm concerned about is sort of the tail of this pandemic. I think we know that there's a lot of people who have experienced, I would just go so far as to say trauma if you lost a loved one and you weren't able to be there in the hospital with them, or a year of isolation, domestic violence that didn't get addressed. Like I think we are all pretty clear on the understanding that there have been more challenges to behavioral health during the pandemic, and that the impacts of that may last much longer than the pandemic itself. And so I'm curious about how you're thinking about what strategies the agency will use to meet what I think we are all anticipating will be an increased demand for services as we're moving out of the pandemic and for the rest of the biennium.
Yes, thank you for the question, Joe Millay. For the record, yes, we have staffing currently that can meet the pre-pandemic level, and so we're thankful for that. Our vacancies have been, especially in the rural counties, have been there for quite a while. Our employees in all the communities know their communities well. They work and live in those communities, and so they can kind of be a pulse to us as well in those communities to let us know what's occurring. Our early intervention services, working with multiple other divisions, the Division of Child and Family Services and others, have really helped and assisted around this post maybe pandemic, or as we see it kind of, leveling off. And so we've really been working on how we can improve those interventions and provide services to those clients. And really it's getting to those that in need, those call lines, the mobile crisis teams, all those early intervention services really are helpful so that people don't have long-term effects from the economic, psychological effects of this pandemic.
And then Chair, if I may, just one follow-up question. Who or where, I mean, this may not actually be your department, but I guess my question is who or where in state government is thinking about the trauma and behavioral health of all the employees who have been, so directly involved in the pandemic response? When you live within the Department of Public Health, you are the behavioral health specialists. The team has been at it for a long time. They've experienced a lot of trauma themselves. How are we taking care of our own?
Stephanie Woodard for the record. Through our Crisis Counseling Assistance and Training Program with our Resilience Ambassadors and Resilience Ambassador Supervisors, we have been working alongside and offering webinars and additional support for anyone who needs it, including state employees. We've had a very close relationship with the Division of Emergency Management and have provided them on-site and off-site additional support. But we have been advertising the availability of these additional support services for state employees really across DHHS and anyone who has had a hand in the response for the pandemic.
Thank you.
Thank you so much for asking that question. I was going to ask that, so I'm like minds. Assemblywoman Titus.
Thank you, Madam Chair, for the question, and thank you, Senator Ratty, for pointing out some of the concerns that I too have regarding telehealth. Is helpful, but there's still times that you need literally to have an in-person meeting. And so back to my same line of questioning that I asked a moment ago in a previous budget, there was a mention that there was a perhaps several week wait list. So could you clarify? You mentioned that there was a wait list for testing, mental health testing, but what's the wait time for actual counseling or referral? So once you say there's somebody in each office in these rural clinics, so that somebody can come in and be assessed or at least say hello daily. What's the wait list for even a telehealth appointment, let alone the wait list for a referral for some actual intervention? Can you give me any of those details, please?
Yes, Joe Millay for the record. For most of our wait list, depending on what it is, can be anywhere from immediate access through our intervention models. Up to 3 days is usually for our REACH or our mobile crisis teams. And then however, should you call a clinic and you need to talk to somebody, there is immediate someone there for you. It won't always be your psychiatrist or your licensed clinical social worker, but we always have someone there. That's part of the REACH team. No matter where you call, you can speak to one of those providers. That is Monday through Friday, 8 to 5 o'clock, those services as well. So we have someone specifically for that REACH team for that. As far as getting into the clinic, into your medical clinic, those wait times are a little bit longer. They're up to a week to 10 days to get into those services.
Right, so there's always immediate access with some sort of immediate access for some referral immediately, but then the actual follow-up, because that's the key. You can have we have this early intervention, you have some of this other stuff right away, but from there, other than an emergency room, within a week to 10 days, they'll be actually have either a psychologist, a psychiatrist, or a social worker or a mental health person be able to see them within a week to 10 days?
Correct. Now, when you say, oh, sorry, for the record, Joe Millay, when you say see, I am talking about telehealth services as well as clinic sites.
All right, so a week to 10 days, no matter. So that's good, and thank you for that. That's better than expected. And if I might follow up with another question, Madam Chair. On slide 20, you had the breakdown of how the rural clinics, and these are rural mental health clinics, to be different than the rural public health clinics where the public health nurse is. But on these rural clinics, you had a breakdown of 72% general funds, 1% federal funds, and 22% other. 22% other, is that from grants, or what is that source of funding?
Thank you for the question, Debbie Reynolds for the record. The other funds in the account represent Medicaid, Medicare, and private insurance that we bill through our central billing unit. We also have a transfer of Healthy Nevada tobacco settlement funds from the director's office, which supports the Children's Mobile Crisis Services.
Right. So there's no federal funds, no COVID relief funds, nothing to actually, from the federal government, you're only using 1% of federal funds to fund this rural clinics?
Debbie Reynolds for the record, we did actually receive some CRF Treasury funds to also reimburse the mobile crisis services.
Is there any possibility of more funds available on either through grants or other public funds other than the general fund to support this program? And is anybody looking at that?
Lisa Sherrick for the record. Oh, sorry.
Sorry, it just seems like an incredibly low number of 1% federal funds for rural mental health clinics.
Lisa Sherrick for the record. So the 1% is our HUD Shelter Plus grant. And I do not disagree with you that we should be looking at other potential funds through federal dollars. And we'll make that commitment that we will do so going forward.
Thank you. Thank you, Madam Chair, for the questions.
Thank you. And we'll finish up this budget with Assemblywoman Benitez Thompson.
Thanks so much. I just had one last question, and sorry, we're still back on the N3171. So on the reduced psychiatry positions and the kind of shifting some of those to mental health. I was wondering how those costs look. I'm assuming, although I don't want to be wrong, I'm not sure at all, that would mean contracts for telehealth providers, or I think I saw on the back end of the budgets that you're reducing out charges to their like private insurance and for those who might have it who walk in the clinic and for their associated costs. So I was just wondering where that cost shift happens if we're doing a reduction of FTEs, then the cost for, I guess, an enhancement in those telehealth contracts or?
Lisa Sherrick for the record, and I apologize. Are you referencing E686, the reduction of?
I'm referencing 68. I think it's 681 on the. Still in rural mental health, so I was looking at so one mental health counselor position in Ely, the psychiatric caseworker in Fernley, one mental health counselor Fallon, one mental health counselor NACA, and then Carson City. So and then one in Hawthorne. So I'm assuming all of the counselor positions are the ones that are going to be substituted with telehealth, but I could be wrong. I'm just trying to get a clearer picture there on that.
Joe Millay for the record. Some of those, the clinic managers are also mental health professionals. So those that are counselors are there on the sites. So there's direct sites there. The others, yes, will be via telehealth.
Thanks. And so what I was wondering then was that cost shift to telehealth, because I imagine that that's probably going to be a contracted service.
Joe Millay for the record. No, those are the currently filled positions that we have.
So you're going to just push the case.
Correct.
So that the caseloads will just shift to existing employees who will then telehealth into that area. So like from Reno or Vegas.
Correct. Joe Millay for the record. Correct. We will. As caseloads shift, some caseloads, maybe in med clinics will reduce. We have that ability to be flexible with those schedules and those caseloads. And so mental health counselor may cover, Carson City and may also cover Fallon.
Thank you. Members, any other questions on this budget before we move on? All right, seeing none, we will move on to 3162.
Lisa Sherrick for the record. Slide 22 provides an overview of our hospital bed capacity, number of budgeted beds, and average daily census and average length of stay per hospital. Slide 23 provides an overview of requested language in the Appropriations Act. We are requesting continued ability to transfer general fund appropriation between SNAM's budget account 3161, NAM's budget account 3162, and Lakes Crossing Budget Account 3645 with the approval of the Interim Finance Committee upon recommendation of the governor. Slide 24 provides an overview of Northern Nevada Adult Mental Health Services Budget Account 3162. NAMS provides behavioral health services for both inpatient hospital and outpatient treatment settings. Services provided by outpatient include the Mobile Outreach Safety Team, or MOST, medication clinic, residential, mental health court, counseling, care coordination and assessment services, along with Justice Involved Diversion, or JID, which include assisted outpatient treatment and the community diversion team. Slide 25. This budget is primarily funded with state general fund, a small portion of federal funds, which is our Shelter Plus Care grant, and we also bill Medicaid, Medicare, and private insurance. M201 eliminates 2 mid-level practitioners and 3 psychiatric nurse 2 FTEs to address medication clinic caseload. In July 2018, NAMS Medication Clinic was serving approximately 1,500 people. As of February 2021, NAMS Medication Clinic is serving approximately 350 people. This decrease is due to the availability of insurance through ACA and greater resources in the community, so people are referred out as appropriate. This also includes a warm handoff. NAMS continues to meet the needs of uninsured and underinsured populations. Slide 26, E901. We are requesting to transfer 1 senior physician from NAMS to the Division of Healthcare Financing and Policy to enhance Medicaid reimbursement related to pharmacy services. This is a companion decision unit previously discussed during the Division of Healthcare Financing and Policy budget presentation. This will more accurately align the position to where it is most beneficial, as well as allow for 75% Medicaid admin reimbursement. E683 maintains 22.55 FTEs vacant through fiscal year 2022, with reinstatement in fiscal year 2023. Slide 27. E684 requests to reduce community-based living arrangement services, otherwise known as CBLAs, through fiscal year 2022. This reduction does not displace any current clients receiving these services, but may result in delays for about 7 to 9 clients to get into housing for FY 2022. This concludes the major enhancements in this budget account. Does the committee have any questions?
Madam Chair, you're muted.
Thank you so much for that. It had to happen once today. And Assemblywoman Carlton, we'll go to you to get the question started. Thank you.
Thank you very much, Madam Chair. So I'd like to talk about the vacancies. So it's my understanding that currently there are 62 vacancies, and the proposal will keep 22 of those 62 vacant through the first year. But I think the bigger discussion is the total amount of vacancies that we have and how we decided on these 22. And to be realistic, even if when the vacancy threshold is lifted for the following fiscal year, do we think we'll be able to fill these vacancies? What is the underlying issue when we've got 62 current vacant positions?
Very much. Jill Millay for the record. Yes, NAMS caseload has drastically reduced, particularly over the last couple of years, and continues through the pandemic as well. And also our vacancy rate has maintained itself at about 26%. When the largest vacancy, though, is that in psych nurse 2s in particular, which that vacancy rate is closer to 30%. The 22 positions that were vacant and will be held during this biennium were chosen because of the caseload reduction. So particularly in the outpatient setting and the inpatient. Inpatient currently are census has been about 15, which is almost half of what it has been historically. Also, our ER wait times are also in half, when currently in the years past, they've been in the 20s. Currently, there's 9 in the waiting in the ERs to be admitted. So with that reduction, some of those positions in inpatient were reduced. Those in outpatient as well were reduced. So we could maintain adequate coverage for those clients that we have seen up to the pre-pandemic levels. So in outpatient services, we looked at those positions that were caseload dependent, and where caseloads were diminishing, those are the vacancies that we held.
And this is Lisa Sherrick for the record. I think it's a valid question about being able to, in the second year, if we'd be able to, I'll use my words, easily fill 22.55 positions, or at least easier, quickly. And my answer is, I don't know. I do know when it comes to especially the clinical positions, that's always been a challenge in Northern Nevada, especially during COVID when it came to nursing positions. We were at a point we were just not competitive in any capacity with the private hospitals due to their abilities to pay or offer sign-on bonuses or things like that to make sure that they had adequate staffing for COVID. So I do think the clinical positions are always a challenge. And that's where, we need to continue to work at that within Nevada to make sure we have the necessary infrastructure.
And thank you very much. And Madam Chair, if I could just briefly follow up. So with the conversations of where we think we know there are mental health needs in the state right now. And we know there are folks that are not reaching out for that assistance because of the pandemic and how maybe they're waiting to get a vaccine. Maybe they're waiting to see if they go back to work. They're trying to maybe handle it on their own, but we're going to go back to pre-pandemic levels at some time. And I think anecdotally, we're all talking about the desperate need for mental health as people try to readjust back to what might not be the regular normal, but maybe a little more normal. Will we be able to handle that with these vacancies? Are we prepared for the assistance that folks are going to need as we move forward over the next couple of years?
Lisa Sherrick for the record. We're hopeful that we will be in a position to provide the necessary services. As I indicated a little bit earlier on in the presentation, we have really looked at this very closely to determine how this might impact our state outpatient services and hospitals. And, yes, while there has been an increase in depression symptoms and anxiety, there doesn't seem to be a direct correlation that it would connect back to actually qualifying and receiving an open case through NAMS and SNAMS. That's not to say if folks don't show up at any one of our clinics that we would not make sure that we connect them to the appropriate resources. And I do believe that the behavioral health services that has been stood up during COVID and the crisis counseling and the resilience project and things like that, and the mobile outreach teams that Ms. Millay had mentioned really are addressing a lot of those things in the meantime. But I think it is still a little bit unclear to us on how this is going to truly look in a year from now. But regardless of the research that we've done and the analysis, even looking at claims data to get some type of picture to see if that would correlate back to our caseloads, nothing seems to indicate, at least from the state services perspective, an increase at this time. But I'm not saying that there may not be, but unfortunately, there's nothing, I don't have a crystal ball to show me what it's going to look like, but based on the data that we use, there is nothing concrete.
We all wish we had a crystal ball right now because things are, especially about 6 months ago, 8 months ago, we really wished we would have had a crystal ball so that we could plan. So I just want to make sure that we're prepared and that we're thinking about it. So with that, Madam Chair, I do have a couple questions on community-based, but I'll yield and let other members ask questions and then come back to be the cleanup hitter if you need me to be. Thank you very much, Madam Chair.
Thank you. I know we have a few more members that have questions. We'll go to Assemblywoman Benitez Thompson next, and then Assemblywoman Titus.
Thank you so much, Madam Chairwoman. I appreciate that. So my question is, I'm just trying to get a picture for my own brain of kind of how things, everything was working across the system. So at the front end of the budgets, we heard about federal grant money to hospitals to help with their psychiatric cases, those, help opening up those clogs in the ER. And so I guess I'm wondering, and then how those folks navigated through the system, if on the back end, we seem to have fewer folks landing up in like our NAMS beds or in civil commitment beds and such. So I guess I was kind of wondering from the front to the back end then, and since we're in the NAMS budgets, I should probably say specific to Northern Nevada. So I guess then those the psychiatric help that we were paying for in the ERs up north, was that then more like diversion, or was it clearing holds? Was it helping assessing on holds? Was it transport to other types of behavioral health facilities?
Okay. Hi, Lisa Sherrick for the record. I do know that one of the community hospitals or programs in the north have actually stood up this wonderful program where they're working with the emergency rooms, and it seems to be that's where a lot of the decline has correlated to, and I believe that might be a grant though, so I'm not sure if that's going to end, and we could provide some further details on that specific program, but it definitely has shown wonderful results for the folks that are in the emergency rooms. That has then made a reduction and with very few people waiting for a bed. I'll also turn it over to Dr. Woodard to provide some additional details.
So Stephanie Woodard for the record. Yes, so Renown's program is doing what we would intend for other programs to do, which is to really truly evaluate individuals to determine if they're appropriate for inpatient beds, so that we don't have individuals that are languishing in emergency rooms that actually don't meet that level of care. And what they have found is that for individuals who are transported to the hospital, they are able to rapidly assess what those needs are and then facilitate transfer to psychiatric inpatient beds in the community when necessary. And those beds include NAMS, but include the other hospitals in Northern Nevada that provide inpatient psychiatric care. We've also provided funding to Reno Behavioral Health for that alternative front door. So instead of individuals going to the emergency room, they have a place to go in the community for a rapid triage so that they're being evaluated as well. From there, they can either refer to their own outpatient programs if they are appropriate, or to other community outpatient programs. They're using our platform called Open Beds, which allows for a real-time inventory of inpatient and outpatient access to care. So those referrals can be facilitated electronically. And then from there, if individuals are deemed necessary for inpatient, they can either transfer them to other facilities if there are beds available and they have the appropriate payer source, or for individuals who are uninsured or underinsured, the grant that they've received has allowed them to admit them into Reno Behavioral Health.
And so this grant, was that granted from the pot of federal money that we got, or was that a separate grant of money?
Sorry, you're still
was
on mute.
for the COVID emergency response grant dollars that we received. So
Yeah, I
it is
think
a direct grant to them.
I appreciate that because that really is significant if we're saying just through having a organized system of care on this part, which we've really been lacking, or we've been trying and working hard to, but it's hard to fund, it's hard to stand up. You've got lots of different institutions and things in place. If that really seems to be something to help move people in a better way to an appropriate bed, then it would, then that's great. That's great if it's really because of people landing in a more appropriate spot faster. I know you mentioned the payer source. So I think, did you say that a piece of this grant would pay for the bed if the person did not have a payer source?
Stephanie Woodard, for the record, yes, that's correct. In addition to that, we know that in our urban areas, so we have a similar program that's happening down in Southern Nevada for individuals who are on fee-for-service Medicaid, the access to inpatient psychiatric beds is very low because of the IMD exclusion. And so what these dollars do is allow additional beds to be open to those individuals so that they can be reimbursed for those services.
Thank you so much. Thanks for putting that all on the record and sharing with us. Thank you.
Assemblywoman Titus.
Thank you, Madam Chair. And thank you, Vice Chair Benitez Thompson, for asking that line of questioning, because mine's on that same issue. I need on the record, I've sat on this committee now for four sessions, and always it's been an issue with wait times in the emergency rooms. We've worked on our mental health bills multiple times to make sure we can help people be moved out of our ERs. And am I hearing you say that there is now some of this stuff we've done actually may have worked, that there has truly been a decrease in wait times in our emergency rooms throughout our state? Do you have an hour or an average? Because we used to get reports on what the average hour wait was in our ERs for then referrals or admitting. And so what's the current wait time now throughout the state in our emergency rooms waiting for a mental health admission?
So Stephanie Woodard, for the record, I think it's a great question and we don't quite have an answer for it yet. One of the goals for using that open bed system is so that we truly have transparency into the system at any one time to see who is waiting in an emergency room or even in a crisis stabilization center that meets criteria for an inpatient bed, so that we can calculate wait times and we can see which hospitals are transferring and which hospitals are receiving. We do not have that data as of yet. We really need full participation from all of the hospitals in order for this to happen. Currently, participation in the open bed system is voluntary. And what we have heard from other states where they have started with the voluntary pathway, they have very differential participation across the system between emergency rooms and psychiatric hospitals, as well as outpatient providers. So many of those states have had to go to mandatory enrollment in use of the system in order for us to get really the full clear picture of what's actually happening within the system. But the goal is to be able to have that transparency so that we can see at any one time who is currently in the system and needs to be moved to various levels of care so that we are meeting those needs. And that will ultimately help us determine where the gaps in services are, where there's the greatest amount of wait time. They can break it down by insurance type and other variables so that we can then be much more strategic in how we are funding different programs to ensure that we're trying to address some of the previous bottlenecks in the system.
Well, you cannot give me a figure right now on what the average wait time is in the emergency rooms for mental health admission?
No, not at this time.
Well, why is that? I know you're changing programs. I know the open bed, but prior sessions, you were able to answer those questions. It became a big issue because we had an average wait, but now all that information is gone.
I can answer for a hospital.
You go, Jen.
Jim Malay for the record. I can answer specifically for Deanie Townsend Hospital on the NAMS campus. And so the average wait time once a packet for admission is completed is 4 to 5 days. So that hasn't changed, but I think when we look at the overall numbers is what you're asking for other hospitals and how long they're actually in the ER before the admission documentation is complete is the numbers that we don't have at this time.
All right, so 4 to 5 days makes sense. Literally spent thousands of hours in the emergency room, and the thing we dreaded when a mental health person came in that we had to keep in our ER, which we were not set up, still are not set up for a mental health person, potential suicide person, and then waiting 4 or 5 days. Literally, I've had patients wait days in my emergency room for that admission. So very interested in if any of this have been effective, lowering these admissions. And as soon as you get that information and once you're able to track it, that would be great. And one other question on a different transfer, Chair, please. My question regarding your physician, the transferring of the physician that you're moving for purposes of the medication clinic. Could you explain that, the need for that a little bit more and how that will help and what the purpose of that was?
Lisa Sherrick for the record. So that transfer is actually a position to the Division of Healthcare Financing and Policy. And that was discussed in Medicaid's presentation. This position does provide oversight and management of the Drug Transparency Program and reporting, oversight and participation of the Medicaid Drug Use Review Board and Silver State Scripts Board, other things such as review and oversight or management of the state PBM and pharmacy contracts, management of the state Medicaid drug rebate program, among many other things. So this position really aligns to what it's doing to support Medicaid as well as DHHS as a whole related to pharmacy services, et cetera.
And you list that as a physician. I'm just curious as to what type of physician. I assume you don't need a psychiatrist for that position. And why is it a physician as opposed to a pharmacist?
Lisa Sherrick for the record. So it is a senior physician. And, I would have to go back and verify why it was not a pharmacist position. I would anticipate because at the time we did not have perhaps that position as well as competitiveness of any high-level clinical positions are always challenging with the state positions.
Right, because I was curious about the term senior physician and what that actually meant, if they needed to have some mental health experience or just a pharmacy license, so I'd appreciate some more details on that when you have that available. And thank you, Madam Chair, for the questions.
Thank you. And we'll finish up this budget with Assemblywoman Carlton.
And thank you, Madam Chair. So I'd like to talk about the CBLAs, the Community-Based Living Arrangement Services. In reading through this, it appears as though there's been a decline in homes that are available, and that's why the resulting reductions in this budget really shouldn't affect any actual service. But I guess that leads us to the question is why the decline in homes? Is it the new regulations that are in effect? Does it have to do with the pandemic? Have we analyzed why there is a decline in these homes?
Joe Malay for the record. We've seen a decline in our CBLA homes over the past couple of years. Partly, we believe it's due to the regulations. Some providers just retire, and so that turnover occurs as well. So either by choice or by not being able to meet the new requirements. And so that's part of the reduction. When we look at actually placements within those CBLA homes, we do look more at what each client's needs are. So while we're able to, no one will lose their home in placements going forward. We'll have to really look at the tiers that they fit in and what homes they can be placed in. Sometimes we can provide supervision and oversight within a group home and not in a CBLA home. So that we do have those options. We continue to look for more providers for both our group homes and our CBLAs in order to place our clients. Are meeting our need right now. Thank you.
And I'm just concerned that moving forward, as we come out of the pandemic era here, that there might be more need. So I'm just concerned that I want to make sure it's available, different levels of care for folks depending upon where they are. We want to make sure they're in the right spot. So I think we really want to know if there's a way for us to address this in the future, if there are any issues that we need to do, but if it's basically just a change in the culture of CBLAs, then that's just to be expected. We are going to make people comply with the regulations after some of the audits that we had. We're here to protect the public and want to make sure they're in a safe place also. So thank you very much.
Assemblywoman Benitez Thompson, I saw you raising your hand. You have a question?
Yeah, I had a quick question. Once again, this is just for my better understanding for the state of record and all that kind of good stuff. I guess I think I heard you say that, so we know that HCQC is closing down more of these CBLAs, really good, because we want good providers out there. But then I think I heard you say you're utilizing other group homes versus CBLAs, and I wasn't sure how I should interpret that or what that meant.
Lisa Sherrick for the record. So I just wanted to clarify, our intent was not to say HCQC is closing down these providers. It appears more so that because they're not able to be compliant, it's more their choice to not be providing.
I appreciate that.
Yeah,
I get what you're saying. I did not mean it in that way. I think thank you. I appreciate that. But the second piece about you're using group homes instead of a CBLA.
Emily, for the record, in order to provide adequate adequate care to clients and their housing needs, we do have some other arrangements that we can make as opposed to just CBLAs. We do have group homes. We have basic group homes. We have the special needs group homes, and we have intensive special needs group homes, so that people will get the housing that they need to be successful in their recovery plan. But it doesn't limit options for just CBLAs.
I appreciate that.
Oh, sorry.
Oh, sorry, it's okay. I was gonna say, I know we're running short on time, and I appreciate that. So I think what let's do is follow up with a conversation with you folks. I just want to make sure that, I want to make sure I'm understanding the qualitative difference between the typologies, the type of the homes that we're setting up or that are set up, and the licensing regulations behind them. I just want to make sure that we're not shifting an issue, which I know that we would never consciously do, but I think I don't have a good understanding of what those other group homes are, the populations they serve. And so I can take that conversation offline. I appreciate your response.
And if I may, Lisa Sherrick for the record, all of those homes are licensed. So these are not now shifting to unlicensed group homes. They're all licensed by HCQC, but we can provide those details and follow up as you indicated your desire.
Senator Ratty, did you have a question on this subject matter before we move on?
I did. I know we're going pretty deep on this one, but just perhaps I could participate in the follow-up conversation with Ms. Benitez Thompson. But I think that what we're hearing from the homeless efforts in Washoe County is that there is still a serious lack of housing, particularly for somebody with a serious mental illness. And we've talked about CBLAs in the past, where the economic pressures of the supply curve in housing in Washoe, where rents are creeping up. And so for some of those folks, it just may be more profitable to turn it to a market rate rental as opposed to staying in the CBLA business. I wonder how many of them are losing purely because of the economics of it. And so I think it's wonderful that we're shifting the current population into appropriately licensed group homes, and that's a really good outcome. And along with the majority leader from the assembly, believe that there's some really positive things that needed to happen there. But I also know that there's pent up demand that we are not getting placed somewhere that is affecting kind of our homeless continuum of care as well. And so I'm concerned about seeing that we're not creating, whether it's more of these or more spots someplace else. And I know that the housing crunch in Northern Nevada makes that all very difficult to make pencil. So I don't know that there's a question there, except for, I know we had talked about restructuring our rates so that rent was pulled out separately. And then, because I think what happens in many cases is when they have to start paying more for the rent, they get less care in a CBLA model. And so just how are we managing the extraordinary housing prices in Northern Nevada in a model that requires typical residential housing?
Okay. Lisa Sherrick for the record. I just wanted to quickly make a comment. So the division, we do have a meeting scheduled at the end of this month to discuss with Washoe County that exact concern that you brought up about the number of individuals facing homelessness that may also have serious mental illness, and seeing how we can, as a collaborative group, figure out some successes to meet those issues. Related to the cost of housing, I will defer to Ms. Millay.
Joe Millay for the record. So our costs were determined when we had a third party auditor come in and look at the cost of housing. So we did have some set rates within our CBLA homes and other rates as well. But we do look at those annually as well to make market adjustments as we can and as the budget allows.
Just a yes or no answer on this one. On the meeting that you're attending, are you connected with the Built for Zero effort that's happening in Washoe County around the homeless? Is that where that housing meeting is fitting in, or is it something separate?
Lisa Sherrick for the record. I don't recall that term being used, but it was is it health? It's the County Health and Human Services that reached out, and
Okay.
There's another entity. I might have missed that. It just literally, we organized that meeting the other day.
That's okay, Ms. Sherrick. We can follow up offline. Thank you so much. Thank you, Chair.
And I just have one last question before we close out this budget. When we talk about the homeless and severely mentally ill, when you look at decision unit M201 and the positions that were going to be eliminated due to the caseload when it comes to the medication clinics, can you tell us how the agency would respond to an increase in demand beyond the projections in the caseload, considering the recommended proposed eliminations for the medication clinics?
Yeah, Joe Millay for the record. Sorry, I was making sure I would give you an accurate response. The medication clinic in particular has had a large decrease in our caseloads. And so when we looked at those positions in particular that were needed for medication clinic, those were the reasons they were vacant. And those were the reasons that they were for reduction. We believe we can meet that caseload, and we believe we can meet it at the pre-pandemic level. Currently, our medication clinic caseload is at 54% of normal. So that's why we believe we can reduce those positions in particular.
So reduce the total number that are there, or would it be better to maybe make that a lower number, maybe only 3 reductions of staff instead of the 5 that were suggested, just to keep the patient level with staff level more in line?
Debbie Reynolds for the record. Ms. Sherrick mentioned at the beginning of the presentation that the Office of Analytics will be updating our caseload projections at the end of the month. Based on those updated projections, it may result in a need to recalculate the caseload positions that are necessary. So we'll have to work with fiscal staff once those projections are available to determine if reductions are necessary to the number of positions included in that decision unit.
Thank you so much for that. I'll look forward to hearing how all that pans out. Members, not seeing any other questions on this budget. So we will move on to our last budget, which will be 3161.
Lisa Sherrick for the record. Slide 28 provides an overview of Southern Nevada Adult Mental Health Services, budget account 3161. SNAMS provides behavioral health services for both inpatient civil and forensic hospital and outpatient treatment settings. Outpatient services include the Mobile Outreach Safety Team, or MOST, Medication Clinic, Program for Assertive Community Treatment, or PACT, Residential Mental Health Court, Counseling, Care Coordination, and Assessment Services, along with Justice Involved Diversion, or JID, which includes assisted outpatient treatment, misdemeanor diversion, youth in transition, and supportive outpatient treatment. Additionally, Stein Forensic Hospital, along with Lakes Crossing Center, which will not be discussed today, provide treatment and evaluation services to mentally disordered criminal offenders for whom there is a doubt regarding their competency to proceed with adjudication. These services are provided both inpatient and outpatient, depending on whether the court determines the client may be a danger to self and/or others, or may not benefit from outpatient treatment to competency. The facility also treats clients determined not guilty by reason of insanity and unrestorable clients who are too dangerous to commit to a civil psychiatric hospital. Slide 29. Budget 3161 is primarily funded with state general fund, a small portion of federal funds, which is the Shelter Plus Care Grant, and we also bill Medicaid and Medicare and private insurance. Slide 30 and 31 outline our three major decision units related to justice involved diversion, projected caseload decreases. This includes M201, it eliminates one clinical social worker. M203 eliminates one mental health counselor, and M204 eliminates 3 psychiatric caseworkers. Over the past week, after thoroughly looking at our caseload data, I have unfortunately determined that the data we've been using going back to 2019 did not reflect 3 of the sub-programs under this overarching program. Our caseload data was only capturing assisted outpatient treatment and not including youth in transition, misdemeanor diversion, or supportive outpatient treatment. I recognize I should have caught this last session and prior to submitting our agency budget request for FY22 and 23. Since discovering this error last week, we have been developing internal controls to ensure this does not happen again in the future. Currently, our point in time count on March 9th, 2021 reports that there are 169 individuals actively served in JID. There are 3 in the misdemeanor diversion, 62 in assisted outpatient treatment, 97 in supportive outpatient treatment, and 7 in youth in transition. With that being said, it appears based on caseload ratios required for these programs, eliminating these positions would not align with program intent. As stated earlier in the presentation, we should be receiving our updated caseload projections later this month and anticipate projections may show a different need, and we will need to work with LCB Fiscal to address any revisions to the budget. Slide 31. E226 requests funds to upgrade and maintain security cameras throughout the SNAMS campus for the safety of client, staff, and the public. E550 requests funding for a new unit dose packager, which converts bulk medication into unit dose dispensing packaging at a significant reduction in medication cost. Slide 32. E680, due to required budget reductions, we are requesting to eliminate SNAM satellite office space and associated operating costs at 3811 West Charleston. This space is currently occupied by the business office, and these staff can be moved to a location on the SNAM's campus or at the East Las Vegas Clinic site. E682 and E683 request to maintain 5 FTEs vacant at SNAMs through fiscal year 2022, with reinstatement in fiscal year 2023. This concludes the major enhancements in this budget account and our overall presentation. Does the committee have any questions?
Thank you. Yes, we do have a few questions, and we'll go to Senator Dunn-Durham to get us started.
Thank you very much, Madam Chair, and thank you for that information. So can you confirm or provide me with those acuity levels of patients and associated staffing needs at the Ross and Neal Hospital? I just want to make sure I'm understanding all these numbers clearly.
Lisa Sherrick for the record. So I am not entirely clear on what you're asking, but I will say, and then if there's follow-up, when it comes to the acuity levels of our hospitals, so each of these decision units are our outpatient services. For our hospitals, acuity is really based on each individual patient. So there's not like a basic acuity level for everyone, that everyone's like a 1, 2, or 3. Not saying it's even we do 1, 2, or 3, but it's really very individualized based on their symptoms, their presenting status when they come into the hospital, as they progress through that process, what their supervision needs are, et cetera.
Okay, so then how did the agency determine that holding the civil inpatient staff positions at the Ross and Neal Hospital vacant rather than the positions in a different unit or program was the most ideal solution to meet that budgetary issue?
Lisa Sherrick for the record. I do apologize. I misspoke. There actually were 2 psychiatric nurse positions that are inpatient that we are reducing. And I'm going to turn it over to Ms. Millay for additional information.
Thank you for the question, Jim Millay, for the record. So during the pandemic, our numbers in our ERs had decreased initially, although we do see them starting to incline again in the ERs. We do have our mobile crisis units out there, continuing to work with the emergency room physicians to get clients into the right treatment venue as needed. But the acuity is all the same. As long as a client meets the criteria for a mental health crisis, they are admitted to our hospital or involuntary civil commit. So that's not where the acuity actually lies. It just have to meet certain criteria for us. And so the elimination, however, specifically of those 2 psych nurses, we have a 30% vacancy rate in our psych nurses too, in the South as well as the North. Those positions are a little bit difficult to fill. And so for those reasons, those were put up for reduction. With that said, though, even though we have that vacancy, now that the pandemic and schools are starting to come back in, one of our strong recruitment efforts is through our universities and our nursing and our medical, psychology, all those disciplines coming back into our hospitals, even on any level, is the way we can recruit and then start to fill those vacancies and help with our needs in our hospitals.
Okay, thank you very much. Thank you, Madam Chair.
Thank you. Assemblywoman Benitez Thompson.
Thank you so much. So my questions are going to be specific to the Justice Involved Diversion Program, the GID program. And thank you so much for mentioning on the record that you folks are going to be re-looking at your data and rethinking the request of the elimination of 5 permanent state positions in this budget. I appreciate that so much, and I'll really just look forward to those ongoing conversations. We know that while it looks like we only serve a handful of, not a handful, relatively speaking, a handful of clients here, 80, looks like 82 between the period of 2017 and 2020, but we know that there's going to be some data cleanup there, that these are folks who bounce between mental health and our justice programs. These are our $1 million Murrays, right? These are folks who cost the system a lot of money if we are not otherwise helping to case manage them. So just want to thank you for that acknowledgement that you put on the record, and just look forward to the ongoing conversations on that particular budget.
Members, any other questions on this budget?
And then one last thing, Madam Chair, my apologies.
Go ahead, and then we'll go to Assemblyman Roberts.
It's okay. And then the same, I'm going to ask staff to follow up with the same conversation that we had on the Northern Nevada mental health budgets regarding the federal grant money into the hospitals for the psychiatric admissions. So same thing about which hospitals got those monies, how those dollars were used. I'm assuming that what was said for, I shouldn't assume that. I guess let me know if it seemed to work in the same way that we heard you testify at working at up north, or if we saw different outcomes for some reason, or if we saw differences in the way the money was used in the way that it affected the outcomes. And we don't have to do that on the record. I'll just look forward to all of us reading that.
Assemblyman Roberts.
Thank you, Madam Chair. And it was just a follow-up on the vacant positions. And from the earlier presentation, we had 62 vacancies in one of the budgets due to difficulty in recruiting people for pay. Is that the experience that we're having with these positions here? I know you talked a little bit about recruitment, but were we having problems filling those positions?
For stamps?
Yes, yeah.
Generally, for the record, yeah, we do have the same issues in the south as we do in the north filling positions. There is a little bit larger pool in the south that we can pull from. So that seems, the turnover seems to be a little bit better for that kind of recruiting. Hope that's your question.
A follow-up, Madam Chair? So as these persist, is there any thought of restructuring the pay grade or moving some of these to contract positions so that you could actually lure people from some of the other work pool to fill these positions? Because I mean, I know our caseloads are down now and they're starting to creep back up. I would anticipate they're going to go back up. And I mean, these are services that are direly needed. Any thoughts of restructuring the workforce?
Lisa Sherrick, for the record, we certainly would love the opportunity to reevaluate the pay structure for clinical positions and nurses, doctors, et cetera. With that, though, comes more money, obviously, that we would be requesting since it's general fund. But we do hire many individuals on contract currently when we can't fill them in the positions, but we do lose a lot of people that initially apply. And then when they find out what the pay is, even if we are able to consider a step 10, they still often turn us down because we're just not competitive to the private sector when it comes to that hourly wage.
Do you have trouble filling the contract positions?
Yeah,
Lisa Sherrick, for the record, typically no, that does not seem to be an issue.
Okay, thank you. Thank you, Madam Chair.
Thank you for the question. And just a follow up to that, we've heard in a number of budget hearings, the contract positions often cost us more than an FTE. Is that correct?
Lisa Sherrick, for the record, yes, when it comes to the hourly wage, yes, it does. And then the administrative cost when we're going through, if we have to go through a temp agency.
Follow up, Madam Chair?
Go ahead.
So, but you lose, or you save some realization in PERS and other health benefits. I mean, I know my wife was a contract employee for the federal government, and they saved quite a bit of money there from civil service. I would assume that's the same here. It was the same at Metro. So is that not captured in the same budget?
Lisa Sherrick for the record, and I apologize, are you asking if we consider the cost of the fringe benefits, PERS, et cetera?
Correct. You don't encumber with a contract position. So the overall expenditure for the FTE for a contract without the other associated costs could be the same, and you could increase the hourly wage, correct?
Lisa Sherrick for the record, that may be accurate. I would have to confirm and get back to you on that. I do know, if I can recall correctly, and I'll make sure that we provide this formally also, if this is a request, is when we look at even, for instance, a psychiatrist position with the state, if you look at the top pay, is it like $95? It's like significantly lower compared to a contractor. So a contractor could be upwards to $50 an hour compared to like $100 an hour or whatever for a state position. So I think if we did I would have to do the calculation on the retirement along with that as to what the difference would be. But I believe there still is a lower amount. And then when it often what I hear, and maybe this is more anecdotal, but I have seen this as well, as I have worked at SNAMS myself, I've worked at NAMS before, is that there are doctors that they do work at various places. So they don't just want to work for the state. They like the flexibility of being able to work at multiple locations.
Thank you for the indulgence, the extra question, Madam Chair. Thank you.
Of course, thank you for the questions. Assemblywoman Benitez Thompson.
Yeah, I just want to make sure that we're adding to the record, because we also did at the end of the last biennia have an audit that came through that talked specifically about our contracted positions within these budgets and across these budgets, and managing those contracts and managing that time can be quite difficult. So I would just reference any members who want to go back to read that. And the division did a lot of work and has done a lot of work once that audit came out to address some of that. But I would hate to leave it on the record that we don't have empirical evidence about some of the downfalls when we rely heavily on contracting out these positions and these clinical positions.
And Lisa Sherrick, if I may, we continue to provide follow-up information, and we actually did receive a request from the Division of Internal Audits last week to provide the information on basically our ongoing doctor's audit verification that we work with them on.
Thank you both for getting that on the record and clarifying that information, especially for new members on the committee that may not have known that. I appreciate it. Members, any other questions on this final budget? All right. I'm seeing that. I'd like to thank you for joining us here with the presentation and being extremely courteous with us for all those in-depth conversations and questions. And we'll look forward to the additional information that was requested from committee members and your work with our staff as you look at those eliminated positions. So thank you. Have a wonderful remainder of your day. And that brings us to the last agenda item, and that will be public comment. And I will ask our BPS staff to see if we have anyone in our waiting room for public comment.
Hello, Chair. This is Michael from Broadcast. I can queue up the first caller if you're ready.
Yes, thank you.
In order to make public comment, please press *9 now to take your place in the queue. Caller with the last three digits, 130, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning. My name is Stephanie Goodman, Stephanie Goodman. I'm the Executive Director of the Dr. Robert Hunter International Problem Gambling Center here in Las Vegas. Thank you for this time. Over the past year, we've stayed physically open the entire duration of the pandemic while adhering to all CDC health and social distancing guidelines. For many of our clients, we were their only outlet and a space where they could receive help, and they are all so very grateful. So we're just grateful we were able to get that funding during the special session, and we have put it to great use. This pandemic is unprecedented, as we all know, and we don't have much data, but we do anticipate an increased attendance as the world gets back to normal. The isolation and significant life change brought on by the pandemic has had a detrimental effect on all of us and surely on our problem gamblers. Specific to that point, I have to give accolades to our state problem gambling program specialists. We were on a performance review call, and in real time, we all pivoted and created an adjunct relapse prevention support program. Our former clients who are in recovery and leading successful lives have felt the impact of the pandemic too. They have not relapsed, but they have thought about gambling significantly more than in normal times. We have materials created by our founder, Dr. Hunter, and we use those to implement this program. And our first meeting on March 12th was so well attended, we may need to open a second session. This is a real testament to addressing issues in real time in conjunction with the state and affecting positive change for our clients. So we are grateful for that. Finally, I believe there's a dire need for awareness in our state. In general, rather than identifying this as a biological condition of the brain, individuals think something is personally wrong with them or their loved one. They don't understand that this is a debilitating and real addiction that lives in the very same part of the brain as alcohol and drug addiction. Only through awareness and the continued research that supports that awareness will we get to a point where this addiction is not viewed upon with shame and coupled with a terrible stigma. We have the tools to help individuals and give them a path to a productive and happy life. We need people to know we are here and that we can help. This is Nevada, and I am a native to our state. Home truly does mean Nevada for me, and I firmly believe that if we are going to be the thought leaders in gaming, we need to be the thought leaders in problem gambling as well. Thank you for your time, and have a great day.
Thank you so much, Ms. Goodman, for your comments and joining us here today. Do we have another caller?
Yes, we do, Chair. Caller with the last three digits, 454. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hi, Carol O'Hare, CarolO'Hare. I'm commenting today on behalf of the Nevada Council on Problem Gambling and myself personally in support of the continued funding for problem gambling services. The funds that are provided in Budget 3200 support critical awareness, prevention, treatment, workforce development, and research for problem gambling in Nevada. These programs stand alone from any other service system or funding sources through DHHS and the state. And unlike programs for other addictions and mental health issues, there are no federal funds to support prevention and treatment services specifically for gambling disorder. I'm also pleased to share that Governor Steve Sisolak has declared March as Problem Gambling Awareness Month in Nevada, following the tradition of previous Nevada governors recognizing the importance of addressing this public health issue that directly affects tens of thousands of Nevadans. This national grassroots public awareness campaign focuses on raising awareness of the warning signs of problem gambling and treatment resources to help individuals and families impacted by this addiction. I encourage you to follow #PGAM2021 to learn more about this initiative. The additional impact of COVID-19 pandemic in Nevada has led to increased levels of stress, anxiety, and fear due to financial insecurity, job loss, illness, and loss of loved ones. These are the exact same risk factors that can lead to gambling addiction, with Nevada already having one of the highest rates in the U.S. and problem gambling having one of the highest suicide rates of all addictions. People who may only have been at moderate risk for a gambling problem may now be using gambling as a coping mechanism and may experience increasing levels of harm that can lead to significant consequences. Providing public awareness of this risk and access to affordable treatment and support resources is vital to our citizens now more than ever. And I echo the comments of Stephanie Goodman at the Problem Gambling Center. I am honored to serve as the Executive Director of the Nevada Council on Problem Gambling, a private nonprofit agency and affiliate of the National Council on Problem Gambling, and to also serve as a member of the Governor's Advisory Committee on Problem Gambling. Both organizations are like-minded in our mission to provide effective problem gambling prevention, education, treatment, and research programs throughout Nevada. And our vision is to improve the public health of Nevadans through a sustainable and comprehensive system of programs and services that reduce the impact of problem gambling. Most humbly, I am blessed to be able to say I am a person who has lived experience with this issue, having just this January celebrated 30 years of continuous abstinence and recovery from my own gambling disorder. Problem gambling is treatable, and the evidence shows that treatment works. We urge you to recognize Problem Gambling Awareness Month by supporting the state's continued funding of problem gambling services as proposed in Budget 3200. Thank you for listening and for your service to our great state.
Thank you, Ms. O'Hara, for calling in, and thank you for the comments that you submitted. And members, if you haven't seen it, it is up on Nellis. BPS, do we have any other callers for public comment?
Chair, the public comment line is open and working. However, we have no more callers at this time.
Thank you so much. Seeing that we have no other callers for public comment, that will bring us to the conclusion of this meeting. And I'd like to thank our presenters, our committee broadcast staff, the members of this committee, and the public who were able to join us virtually here today. And with that, this meeting is adjourned, and I wish you all a very productive day.